This is Professor Ariel Ortiz Lagardere, streaming live from the International Bariatric Club Studios at the International Institute of Metabolic Medicine in Baja, Mexico. It is our great honor to announce that today is the 102nd IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series was created during the beginning of the COVID-19 pandemic in March 2020 and is a collaboration between IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars is to provide a free and first-class surgical education globally to improve patient care. And in addition, the 5th IBC University of Oxford World Congress will be held from September 17th through the 19th of 2024 at the University of Oxford, United Kingdom. For more information, go to ibcclub.org. The theme of today's multi-streams 102nd IBC University of Oxford Hot Topics in Bariatric Surgery exclusive webinar is Game-Changing Technologies in the Minimally Invasive Surgery and Endoscopy Field, and will feature experts from France, Brazil, Hong Kong, the United States, the United Kingdom, and the United Arab Emirates and Mexico. The IBC University of Oxford Webinar Partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, Medtronic, Ethicon Endosurgery, Stryker, our gold sponsors, ConMed, Reach Surgical, Carl Storz, USGI Medical, Blue Sail Surgical, David Medical, our silver sponsors, GT Metabolic Solutions, our bronze sponsors, Moon Surgical, Intuitive, Arthrex. The chair of today's webinar is Professor Lee Swanstrom from the United States. Professor Lee Swanstrom is Chief Innovations Officer and Scientific Director, IHU, Strasbourg, France. Also Professor of Surgery, Oregon Health and Science University in the United States, and Honorary Fellow of the Royal College of Surgeons of England and Brazilian College of Surgery. I will now ask Professor Swanstrom to introduce our esteemed moderators, Professor Silvana Perretta from France and Dr. Enas Al-Alawi from the United Arab Emirates and Professor Philip Chiu from Hong Kong.
Thank you very much, Ariel Ortiz. It's always hard to follow up with you. Such a dynamic speaker, but it's certainly my pleasure to host this 102nd webinar by the IBC. It does such a fantastic job, and it's always a pleasure. I learn almost as much as I'm sure many of the witnesses to these great talks will be. So this is also one of my favorite topics, advanced technology, and I think everybody will enjoy this and learn a lot. So I'm helped today with a very distinguished panel of moderators, as you heard. And I'd like to introduce them. You already heard Silvana Perretta, longtime friend and my colleague in Strasbourg. Silvana is our Director of Education at the IHU, Vice President of the ERCAD France, and a Professor of Surgery at Strasbourg University. We then have Philip Chiu. Professor Philip Chiu is a good friend as well in Hong Kong, Chinese University of Hong Kong. He's got numerous titles. He's on the Faculty of Medicine at the Chinese University, Director of the Endoscopy Center in the Prince of Wales Hospital, and President Endoscopic and Laparoscopic Surgery of Asia, known as ELSA. Finally, Dr. Enas Al-Alawi from UAE, joining us as well for a moderator. She's head of the Department of Bariatric Surgery at Novomed Dubai and Abu Dhabi, a Director of Evidence-Based Medicine and Research Center at Novomed, likewise an academic researcher who focuses on bariatric surgery. So thank you for our moderators, and I'm going to turn it over to Silvana Perretta to introduce our first speaker.
Galvao, Neto. Manoel is a surgeon and endoscopist, a scientist and innovator, and he is director of bariatric research at Orlando Health in Orlando, United States, the head of bariatric endoscopy at Mohawk Bariatric and Robotic Center in Indore, India. He also is the head of bariatric endoscopies at Elias Ortiz Company in Tijuana, Mexico. He's the scientific director of ERCAT India, and we're very happy to have him there, join the family. And he also is the co-founder IBC, director of IBC Innovation, and co-director of IBC Oxford Congress. And Manoel is going to open this fantastic session, and he's going to talk about autonomous endoscopic suturing, eliminating human error from the equation. Manoel, is that possible?
So Silvana, thank you very much for this kind introduction. I will try to handle to the task. Again, joy, pleasure, and honor to be among you today in this 102 IBC webinar. So let's jump onto my presentation. And I really hope you guys are seeing that. And what we have now in terms of endoscopic suturing, we can see in the screen, we can remodel the shape of the stomach by means of endoscopic suturing, endoscopic plications, and a mix of them. We have now 3 established platforms. One of them has a FDA approved for the procedure. The other 2 have the approval for tissue approximation, looking for the procedure itself of gastric remodeling. And with that in mind, and you can see the video how we can remodel using them. So let's jump on that. So what we have now in terms of endoscopic remodeling by that, we have level 1 evidence by the source of merit trial, prospective randomized control trial against diets. And you can clearly see here on the right side of the screen, if you follow the blue line, the patients that was randomized to have the procedure, they lose weight, and after the dotted line, they keep it. And when we cross the patients randomized for diet, diet's doing what diet does, nothing, and then they go up and they follow the ones that have the procedure. So 45% of delta in between groups favoring endoscopic suturing, and 77% are good responders for these up to 2 years. So very safe, 2% assess of severe adverse events. You see pergastric abscess, upper GI bleed, malnutrition was one human, but handily very well. If control comorbidities, because the patients effectively lose weight. And you can see here that is a non-refluxogenic procedure when compared with sleeve gastrectomy. So that, and this study was published in a very important journal, The Lancet, and allowed this procedure to be recognized and approved by the FDA. If you see pooled data since 2012, more than 15,000, almost 16,000 procedures in the peer-reviewed literature. Important to see 36 months, 14% total body weight loss. That is really satisfactory when we are looking in terms of endobariatric therapy. So is that's the data we have. And that said, there is still intensive learning curve to get up to speed and to do a good procedure. And you can see here in 2 published papers that can be like 38 cases in an early paper or 10 cases in a later paper, but still you have a learning curve to get over that. And those devices are considered labor intense in terms of acquiring the skills, and any skills that you have as an advanced endoscopy can't be used on that one. There's a new learning for that. So it impairs and impacts on scalability of the procedure, because less people learning, less people doing. So we have to get up to speed on that. And the question is automation can be the answer for shortening the learning curve on that? And this is the device I wanted to show to you. Is an automated suture, and pretty much get in mind what we have with staples, electric staples, mechanic staples. So you can see here you have a motor engine, you have a lot of electronic materials, and you have on the tip of this, and I'm about to show you the capability of do some suction. And by pressing a button, you can see the suction applies is a model here. And you can see here, you press a button. And then the system will suture automatically on that. So now you can see that better in a cartoon. So you can see that get your scope or your device over to, you position that inside, you remove the scope, as you can see, then you apply suction, and then the automated suture will go there to complete the suture itself. All the suture, the cinching, and everything is being automated. So you remove this device and you change for a new device, and you go for more applications to do that. So this is what the cartoon tells you, how you modify this before and after. And let's see real life, how those cases are on real life. So this from the study, the courtesy of our friend Ivo Bozowski from Gemelli Hospital in Rome. So as over tube, you position your scope, pretty much you go up to for the greater curvature, and you face the incisura ahead, or you get a position on the greater curvature. So you lock it, then you remove the scope, then you apply suction, but that, and then again, you're gonna press a button. You need to see everything green. So you see it make noises at each go, those sutures around 6 centimeter suture. Then you unlock that, and then you evaluate those sutures that you can clearly see here. There is indeed a suture. So let's see a case we did in Czech Republic with our friend Ivan Machika. So this is the result of 5 sutures applied on this automated, and the learning curve for me, that was like less than 1 day by using that in a model and then just jumping for the case. And it was very safe, as you can see here, and very satisfactory on that. Data. So we have the first data coming, the first in human from Bertrand Pesnava in Madrid. And it's a very good early result of 16%. You see that in green, sorry for the color, of total weight loss in 6 months. But then we have to go to a more reproducible data with more centers. So the results now is a multicentric center, 3 sites in Europe, and 12 months follow-up. It dropped for around 14% total weight loss, but still very good. They now are going to a new trial on that. The early results are very satisfactory. A safety profile very good. And what I wanted to highlight to you is that what is the future comes. So in the near future, you're seeing the new prototype. They will remove the scope. So the optics is going to be on the device. You're going to have a disposable part that is the distal part, and you have the motor as you can connect that and do. So again, getting back to like a stapler that you position, automated, and fire. And on the future, they are expecting more automation for that. So with that, I conclude and on my time, and we are open for questions that I'm sure they're gonna be very sharp.
Thank you, Manuel. That was a great presentation and fascinating technology. And I'm sure we will see quite a few questions out there. I'm going to take the director's prerogative and start with that. So I love that slide that said scalability. And while this might shorten the learning curve somewhat for endoscopic suturing, I'm sure that looks like a very expensive device. Each one you dispose. You think the cost is going to be a factor for how widely this will be adopted?
Yeah, absolutely. Cost is something that's very important. And what I heard from the company, and they are prepared for scalability. So a good thing about having so many electronic on this device is that electronic, it will have scale. It can go very, very cheap of the servo motors and the computer chips on that. And in the hour, if the cost is prohibitive, nobody gonna do that. And scalability not gonna be, the needle not gonna be moved.
And of course, surgery is not inexpensive in and of itself, so I have to compare it to that.
Yeah.
So I'm going to call on our panelist, Professor Chiu. Do you have any questions for Manoel about his great presentation?
Yeah, I think it's a wonderful presentation, and I have interest in terms of this development of the endoscopic suturing, and obviously, I am also very interested in automation because that would control the quality of the suturing and to enable more people to perform such a procedure. But I can observe, Manoel, Galvao, that there are many types of suturing that seems to be all achieving some goal. So what kind of ideal suturing in the stomach that you think would be the gold standard? Because now you can see the development of the device also depends on the type of the suturing or the shape that we end up with the endoscopic sleeve gastroplasty or other bariatric procedure. So what do you think is the ideal way to suture?
Thank you, Professor Chiu, and as usual, very sharp question, very on the target. The answer is that an endoscopic suture must be full thickness, must be applied in the body, and maybe on the future in the entrance, we know the gastric body and the fundus on that. They have to remodel the stomach. Shape of the stomach is something out of debate, even in surgery, because if we look at this sleeve gastrectomy, that seems to be very reproducible, and on practical ground, every single sleeve gastrectomy is different in shape. So I think you have to modify the stomach and reduce the stomach, remove the stomach significantly. Let's say more than 50-60% of that is arbitrary, I don't know, but significantly, and have to be full thickness. So any device that do that will fulfill its tasks on that. And if they can be, as you can see, that automated, even better. And in terms of automation, so what we predict on the future, my dear friend Philip, is that we're going to have sensors on the chip of the device in the body, and we can see from outside the position on that. And if the machine can go inside the stomach, and you might have some 3D reconstruction live, that you can position automated that. That's going to be the future that one can predict on that.
Nice response. Professor Al-Alawi, do you have any questions for our speaker?
Yes, sir. Professor, you mentioned the full thickness. You know, when we're stapling, we've got these different type staplers, and we choose the stapler according to the thickness. Is there something that can help when you're doing the endoscopic suturing in terms of the thickness, or is it all just a one standard size?
Yeah, absolutely. That's a fantastic question. So far, we just have one standard size. And if you use the other suturing machines, you can calibrate by means of visually what much you can get inside. It's not perfect for that, but they intend to do that. And you are limited, for example, on the endoscopic, the suture, you're limited by the size of the big tower, that's 1.5 centimeters. And on the one who do plications, you are limited for the size of the jaws that can get the tissue from 3 to 6 centimeters depthness of that. But what I can tell you is that basically you can feel that when you're passing that, and experience can tell you. But on this one, the thickness is not that much of a problem because they're going to be sucked inside, and most of them are that. But I agree with your concern. We might need something that we can measure the thickness, and advancing on that as the sensors becoming cheaper and more smaller, we can do endosonography to check that before.
Yeah, sir, you mentioned something about the sensor. Can you kindly elaborate? What did you mean that there is a sensor? Does that sense the thickness of the tissue? Yes,
that's preparing for the future to have an endosonography sensor on the chip of the suture, so they can sense the depth of the bite. They can sense the thickness of the suture. They can calibrate the aspiration. It's not there yet, but you see the new prototypes. We really expect that advances to come.
Looking forward to it. Thank you, Professor.
Likewise.
So we have quite a few questions from the audience. I'm not sure we're going to get to all of them and stay on time, but maybe I'll run a couple across to you, Manoel, for a brief answer. Rob Cunningham asks, what do you tell patients about this vis-a-vis surgical treatments like a sleeve gastrectomy?
I think it's sleeve gastroplasty. So we tell patients that is a new option that is already validated. So we use in the lower end of the BMIs of obesity. We have data up to 4 to 5 years. There's a very good safety profile and an efficacy that not compares with surgery, but is close to. So it's a new weapon on the armamentarium of battling obesity. Is that what we see, what say to our patients?
Great. And maybe we can do one more quick question. Dr. Stylianidis asks, what would be the follow-up after this procedure? What sort of dietary and activity recommendations?
That's a great question of our friend Stylianidis. So salute from here, from Orlando. The follow-up is basically the same follow-up of bariatric surgery. Sometimes a little bit more extensive. So you see the patient 1 week after, 1 month, 2 up to each month at 6 months, and then at 3 months at 1 year, and then you follow the patients like at least at 3 months following that. So that's the follow-up. What you expect is the patient have an acute pain for 4 to 16 hours, then it fades. At day 3, patients feel very, very well. They can start getting a liquid diet to try to keep it around 1 month so that the suture glue outside, serosa position, and then is the bariatric follow-up.
That's great. Thank you so much for that wonderful talk. Really appreciate it. And I think we'll move on to the next speaker in the introduction. Thank you, Manoel. So I'm going to ask Professor Al-Alawi again to introduce our next speaker. Ina, can you introduce our speaker?
Yes, our next speaker is Professor Sanjay Purkayast. Professor is a consultant bariatric upper GI surgeon at St. Mary's Hospital in London. He's also the director of Imperial Private Healthcare of St. Mary's in London. Professor is a professor of surgery at the Brunel University of London. Professor Purkayast is going to speak to us about energy and stapling technology within the operating room environment towards first-class outcome. Professor, the floor is yours. Professor Sanjay Purkayast, is he with us?
Sanjay, we don't have your sound yet. Perhaps your mute's on. Sanjay? I see his mouse moving, but maybe if you hit the display mode on your PowerPoint. Still can't hear you. Gloria, can you access his? It's frustrating because it looks like a fantastic talk.
Okay.
Maybe you can move the next presentation, Lee, and
Yes,
then
we
we get
can
back
probably
to
move
Professor.
on to the next presentation, and then we'll go back with Dr. Sanjay because we can't hear him, so he might need to.
All right. Is Ariel Ortiz ready to talk, or shall we go to Professor Teixeira's?
Teixeira is always ready.
Okay, so let's go to Dr. Teixeira's. Always, we were saving the best till last, but since Andre is ready, we'll go with him. So I'm happy to introduce Professor Andre Teixeira as Vice Chair of General Surgery, Director of Bariatric Endoscopy, and the Director of Bariatric Surgery Fellowship at Orlando Health in Florida, and a very well-known surgeon in the minimally invasive field. Andre, the floor is all yours. It's good to hear what you have to say.
Thank you very much for the kind presentation, especially coming from you, Dr. Swanstrom. Amazing. So I'm entitled to speak a little bit of the surgery robot of the 22nd century and what I kind of see what's going to happen. I'm going to give a little potpourri on that because my biggest talk is going to be in September in Oxford on a subject similar to that. So let's get started. So if you look at it, bariatric surgery at United States robotically, right now we have 43% of all the cases are being done robotically. By June, July, we expect it to be about 51% of the cases will be done robotically, which is amazing. So the growth is real. So when you look at the new platform, soft tissue, right? We still have the Intuitive Da Vinci, which the new platforms coming out, I think is in June or July. We have the SP platform. As people know, they have the Hugo, Medtronic, Ottava, CMR, a bunch of different ones are out there. And very few are able to come into the United States. Currently, you only have Da Vinci, but we know we have Hugo, CMR actually working on their FDA trials, right? We have Vicario still kind of working on their process, but it's a very exciting robot also. Those are the single flexible port robots on your left, right? We have the Ion, which is have revolutionized the way we treat lung cancer. In terms of outcomes, it has shortened from 2 to 3 years of detecting a nodule and proving to have cancer and do the operation to about a year, and sometimes less. In our institution, we have shortened that to 6 months, which is impressive. And then we also have the rigid or multi-port robots. There we have several different ones. The multi-arms like CMR, Hugo. We have the Da Vinci, as we know. We have the Moon Surgical and so forth. So there is a new generation of robots, especially outside the United States, which is very exciting. When you look at the future or near future, right, you're going to have a modular, smaller robots, single versus multi-port. Which one's going to be better? In the luminal with SurgiQuest coming up now with for the upper and lower scopes. AI with simultaneous assistance, surgical teaching, incorporating patient data into the case, which some institutions are starting to do that. We are doing that already in our system. Data analysis, simultaneous correction of movement, outcomes of improvement. I'm going to show a snip video of things that we are playing with it to incorporating on shorten your learning curve and also help you with teaching new residents or fellows for that matter. Key technology, wire-driven manipulation. We already know that. We were expanding that even more. Master device with teleoperation, right? We're starting to look at that, especially with proximity and hub. Imaging technology. There are now some new cameras coming out that will be able to detect, like for example, prostatectomies. We're able to infuse them with specific markers. As we remove the prostate, we're going to see if we left any residual or any cell or anything that will light up with a specific wavelength of the camera. So you're going to know a true confirmation of removal of the specimen even before you send to pathology. Vision assistant with AV and VR, which I'll show you in a few minutes, a video that we're working on it. Haptic feedback. This is very near. Within a couple of months, we're going to have that already on some new systems. In autonomous surgery, are we there yet? Well, I think we're getting closer, but we're not there yet. But we are getting very, very close. I think this is an exciting robot. Vicarious is a single port system. They have an elbow, a shoulder, and a wrist with a very small camera attached to a single port. Initially, it's supposed to be a 15 millimeters, but it looks like it's going to be an 18 millimeter. I'm very excited about this single port robot, actually, to be able to see this. And the console, you can see it's a very small console, 3D screen with a goggle. And what I like about the goggle is this. The goggle, as you move your head, it moves the camera, right? So that is fantastic. And why do I like that VR shaped goggle? Is it blocks everything, the 2D view on my side. So instead of just having a regular glass, I have a full immersive VR goggle that will allow me to see a three-dimensional view of things. And how do you bring surgery to the next level, right? Right, interpretive skills. So data have become a big thing. And I think data is going to be what's going to change a lot of the robots of the next future, right? We are able to look at movements, and with the movements, we're able to analyze them and decrease the amount of unnecessary movements that we do for each procedure to gain time. Time is not speed, it's the opposite. It's gaining movements and decrease unnecessary movements. We're able to sustain what we need. Same thing, we looked at it on validation development of objective performance, especially with prostatectomy. When you look at bladder mobilization, an expert versus a novice, you see their hands and the movements are all over the place. With an expert, you are able to condense into a smaller field, especially with the seminal vesicle. Look at that, they're all over the place again. So as we move a learning curve, right, we're able to condense our movements, especially on a 3D manner, to a more smaller square of work. And AI is going to help you with that. So how do we see AI? AI is two different patterns: symbolic learning, machine parallel learning. Oh yeah, we know machine parallel learning, statistical learning, deep learning. This is so far advanced, but I think we're starting to see some machine parallel learning. We've been able to replicate some things here in our institution that we're trying to see how we're going to deploy them for a learning perspective. In the symbolic, you have robotics and computer vision, and then computer science, right? You have the supervised learning, unsupervised learning, reinforced learning. We're still working on the supervised learning perspective, and that's going to take time. But AI is going to be a big thing on robotics. So robotics, supervised learning, data analysis like never seen before, virtual proctor, preoperative planning. On our ORs right now, we are doing data analysis of an entire operating room. We have 11 cameras on our OR doing analysis of not just the surgery itself, but anesthesia placement, where our assistants are, trace movements in and out of the room, so we can standardize and be able to become even more streamlined with the AI data that we're collecting so far. We have collected 300 cases on that supervision of AI supervision. You are analyzing those cases now. As you can see, we've been able to do it by duodenal anastomosis. I'm working a pattern to be able to minimize my movements of my arms to become 100% efficient without speed, without being sloppy, without being unnecessary movements that will delay your case and keep the patient long in the operating room and longer under anesthesia, right? As you can see, we're able to pinpoint my wrist and my elbow and develop a square where those arms should be working 100% of the time, my left and my right. And we analyzed that it's 100% precision from that perspective. So right now, we have 25 cases analyzed on that, and we're looking more data so we can come up with some more reproducible, so we can deploy this on our cases. We're gonna have Tile Pro with the cases showing of the surgeon, the resident, the fellow, where their hands are, so they can see and keep on their hands on the square and to increase the efficiency. Again, mixed reality, full integration in operating room, virtual surgeries, as we're already doing telepresence, instant data analysis, and full integration of AI. This is kind of a video of what we see happening in the near future, especially with our system. This is actually happening to a certain degree already with our lung program, especially with our ION technology and some other company that we're using. We're able to do a full immersive teleproctoring and mentoring of surgical cases bidirectional, which has been phenomenal for their lung nodule program. Like never seen before, we're able to jump in on the cases and allow and help the other surgeon or the other pulmonologist to learn and proceed in a safe manner for the next case. And that's what we use, the Medoptic. We're able to, this is exactly what the physicians see on the other side. We're able to teleproctoring, and we do the same thing on the opposite. Our physician would jump in on their cases with the same thing. So it's a two-way navigation system. And this is what we're doing with us, with bariatrics, that we started doing with robotics, also with thoracic. It's a VR 360, completely immersive. We are able to teach our technique, show them the cards, what we are using. We go into a room, which I try to, each one it shows you what we need, cards, table, instruments that we're using, settings of our energy, and so forth. We have all of our data, support by data, everything that we do. So it's just a quick snap picture of what we've been able to accomplish to facilitate the learning of the new surgeon that want to learn a new technique like a dual adenosine switch or a single anastomosis switch. So we're able to visualize. Now our next step is to incorporate the movements of our hands outside into the same video that you're seeing now. I know we're running out of time. We have a couple more speakers, but just so you have understanding. So this is what we're doing right now, our Advanced Robotic Surgery Center. We have telementoring, proctoring, virtual, case analysis, completely of the room. We're breaking down every surgeon. This is actually a data analysis for our lung lobectomy. We are finalizing our switch in our bypasses, so we can be able to actually present in September in Oxford. That'll be the first time I will present this data, so you can see what's going to be the future. Thank you very much, and sorry if I took so long. Thank you very much for the opportunity.
Thank you, Andre. That was fantastic, and you didn't take too long. You're just on time, as always. So fantastic job. Very, very promising look at the future. Maybe I'll ask Professor Chiu, our robot guru here at the IBC, to pose a question or two for you. Philip?
Yeah, I think, Andre, it's a really interesting, technology that you have outlined, especially in terms of how AI is going to help or driven the development of robotics as well, which I also believe that this is going to be one of the game-changing technology. So, and you play a video, which is very interesting, that the expert who is, engaged in another activity is going to help, surgeon in the OR. So, how do you visualize? Would you think that in the future that you are going to do remote surgery primarily by a surgeon from a distance, or actually the surgeon who are senior is going to help somebody at the OR through a telementoring? So which direction do you think is more likely to happen?
No, so great question, Professor Chiu, and very humble for you to ask me those questions. So, I think, first of all, we have the speed of internet, right? If the speed of internet is real life, then I think we'll be able to do that, like you say, the first cause, which is we operating from distance. Second, which I think is better because of the speed of internet, it is Actually, I'll jump on my console. You're in your console. I can walk you through the surgery. If you need to, I'll take over the control and walk you with your hand in there so you learn the movements. So it's kind of sort of proctoring, but we are working together like we did in open surgery, right? Our hand was on top of your hand to teach you the maneuvers. That's how I learned my open techniques from back in the days. So I think we're going to do that. To me, that would be the best way to do for actually teaching residents and fellows, right? I have the robot too, and I walk them through my hands. So I think this is two ways that we can go. I think it's going to depend on the speed of internet that we have.
Yeah, I think I fully agree with you. And I think also this is really nice that, you know, in the past when we are even teaching laparoscopic surgery, you can't actually do it, you know, by the same, like hands on hands. But in this platform where we share in common by the internet, in fact, this is a really nice concept. I like it really much. I believe that will be the future.
Me too. So it's two of us.
Great. Silvana, do you have any questions for Andre?
Philip stole my question, but let me rephrase it in a little bit different way. I'm sitting here at ERCAT where the first Lindbergh operation was born. This was more than 20 years ago. And it was magical if you think about all the technical difficulties that I had to overcome in order to make it happen. And still here we are discussing if it's doable, if it's possible to operate remotely. So what is your take in that? Because animations are beautiful, but I was taught never to believe animations. So how are you going to break the barrier of those 2 milliseconds in order to make remote surgery really possible?
Dr. Perretta, thank you for your question. It's always an honor. You know, you guys, ECOT has always the most amazing, as I call, toys there. So listen, the 2 milliseconds, I agree with you. When you add the 2 milliseconds delay, it's a big thing. That's why I'm very curious to see, for example, Starlink. Starlink is supposed to decrease that 2 millisecond delay by almost none, right? I really would like to see a second trial, right? Or go to for a case done on that matter, like what you said, like done in the past, using the Starlink to see if the speed of that 2 milliseconds would make a difference. If it would be way shorter, it would be unnoticeable, right? So I think we have to think this way, right? Especially as we start, not every place is going to have a robotic surgeon or a robotic trained surgeon or a surgeon for that matter, right? You might have a robot but doesn't have a surgeon. So I think we need to think about that. There's a shortage, right, of some professionals, especially here in my country. There's some shortage of surgeons. So I think the future, if we're able to fix that delay, why not? Why not give another trial? I mean, what do you think?
I think why not? But I think it's going to take a while in order to really have the availability of such systems and to democratize it, which is what's going to make really a difference. But I'm an optimist, so I hope that it's going to be much more than an animation in the future.
I agree with you 100%.
Great. Enas, do you have any questions?
Yes, Andre, very, very clear, very innovative. Thank you very much. But just from a future-oriented mindset, do you see a room for a disposable robot? There is a lot of talk about disposable robots, so they're more kind of practical. But do you see a room for that?
Great question. So I think it's all about cost, right? So if you're right now, let's just say a robot here approved by the FDA is $2 million, right? Plus $200,000 per year just for maintenance, right? If I'm going to invest that $2 million in a robot, I need to get my revenue back from it, right? So if the disposable robot has to be included in the cost of the surgery, right, to be able to be disposable, And wherever we're going to do it, you have to also generate some income. I mean, just business perspective, right? So I don't know we are there yet to be able to have a disposable robot that financially makes sense, right? But can we go in that direction? By all means, why not? But as of right now, I don't think we're even close, just because of the cost of the technology is so high to develop such a thing.
I think it's coming. And you'll be the first to use it.
Oh, I would love to.
All right. I think since we're running a little bit short on time, Andre, that was a fantastic talk, and really appreciate you joining us on this webinar. And we look forward to the future that you described. So thanks so much.
Thank you so much.
Professor Alawi, I think we're ready for our next speaker. So can you introduce
Professor Sanjay again?
Actually, Philip, maybe we'll change order a little bit. Philip, can you introduce Professor Ortiz?
Yes. Yeah, my honor to introduce Professor Ariel Ortiz Legendary, who is, of course, very well known. He's a co-founder of IBC and also director of IBC Communications. He's a professor of surgery in International Institute of Metabolic Medicine, Baja California, Mexico, and also Center for the Future of Surgery in the University of California, San Diego, United States. And I think Ariel is going to tell us about the Nanoscope Minimally Invasive Technology. Can it redefine diagnostic and therapeutic laparoscopic surgery? To you.
Very honored to be with such esteemed colleagues and friends. And I want to thank Harris Kwaja for inviting me to today's topic on minimally invasive technologies, redefining diagnostic and therapeutic imaging. This is our 102nd International Bariatric Club University of Oxford Surgery webinar, a long-standing series that has an important viewership globally. These are my disclosures. And this is a great picture of the global event that we have every year in the United Kingdom at Oxford University. This is Christchurch Hall, where from a journal club, we have converted ourselves into the world's largest bariatric surgery society. So congratulations to all the members globally. At IBC, we're sponsors, our sponsors of industry are considered more than sponsors. They're considered our allies, our strategic partners in developing technologies and advancing these technologies to improve patient care. So in this specific case, we're going to be talking about Arthrex new visualization system that's been developed for the moment for as an alternative, as a miniaturization for arthroscopy, and we're going to develop this topic to see any further application. They describe this as a 3-in-1 chip on a tip disposable camera system with connectivity to a tablet control system, 1mm imaging sensor, LED lighting on a tip, image management, and OR integration. This is a video of the device. It's a closed circuit with a camera and a display, but here you can see the size of the needle scope, which has several different lengths, and its application in arthroscopy. Why miniaturize? And this is the question we should all ask ourselves. Well, when we work in certain disciplines like bariatric surgery, we're all accustomed to using the 10mm scope. And in the size of our patients and their abdominal wall, well, tissue lesion is really not that important, in a sense that we will not be using a 5mm scope except in very rare cases, and extremely rare to use a 3mm scope in a bariatric surgery. Having said that, when you see this slide, you can see the area comparison between a 10-5-3 and the nanoscope in surface area. We're talking about the surface area
that in turn correlates to the tissue damage. This is why minimally invasive surgery is always trying to miniaturize the approach because of the impact it has on the overall procedure and the recovery time. Here you can see the diameter comparison of the typical 4mm scope used in arthroscopy, and if you include the sheath. But when you compare the 4mm scope to a 2mm scope, well, it's around half the diameter. But when we compare not diameters, but area, that's a different story. We're talking about an area of 27.3 square millimeters versus 4.5 square millimeters. So one thing is to talk about diameter, and the other thing is to talk about the actual area that is being invaded with a scope. And when we see this in a graphic, we can see that a traditional scope has a lot more invasive and tissue injury than a nanoscope, as you can see here. What is the limitation factor in miniaturization of visualization? Well, of course, the quality of the image. And here you can see the size of this camera, 1mm camera, and LED system that is a chip on a tip of an actual almost wire. And what does the visualization look for? Well, at least this technology has been developed to give arthroscopy another option of miniaturization. As you can see, the quality of the image is exceptional. This device is a visualization device for diagnostic procedures and, of course, therapeutic procedures. And this is why the company has developed a line of disposable instruments and reusable instruments to be able to manipulate that tissue accordingly. And you see all the different instruments, sheaths, and something that really caught my attention is the customization level of these instruments. Here you can see the tip of this instrument being bent, and once it's bent into the desired size, it still functions. So that's really exceptional. What is the goal here? The less invasiveness, the less tissue damage, the less anesthetic needed, the less pain, and the quicker the recovery, which in turn could definitely change the approach of at least an arthroscopic procedure from an operating room to a less specialized suite, as you can see here. What has the literature published? Well, here we see this publication by Bratzel et al. An in-office diagnostic needle arthroscopy using the Nanoscope arthroscopy system. And they found in their conclusions to be a safe and cost-effective procedure, which improves clinical decision-making and is an effective alternative to MRI visualization with an extremely low complication rate. One of the tables that caught my attention was the comparison between the advantages and disadvantages of the procedure. And the advantage is definitely shorter delay in diagnosis, which is something that we all as clinicians could benefit from, decreased, as you can see here. What has the literature published? Well, here we see this publication by Bratzel et al. An in-office diagnostic needle arthroscopy using the Nanoscope arthroscopy system. And they found in their conclusions to be a safe and cost-effective procedure, which improves clinical decision-making and is an effective alternative to MRI visualization with an extremely low complication rate. One of the tables that caught my attention was the comparison between the advantages and disadvantages of the procedure. And the advantage is definitely shorter delay in diagnosis, which is something that we all as clinicians could benefit from, decreased operative burden, and more accurate and real-time diagnosis. What they found is disadvantages was the workflow, time, resources, and learning curve, which is basically something that you're going to find with every type of new technology. Here we can see a video of the procedure being done with local anesthetic, an in-office procedure. You can see the screen of the nanoscope at the end, the introduction of a trocar. That trocar is going to be instilled with saline solution, and the introduction of the 2mm scope. And you can see in the lower right-hand corner, the visualization. Now, this is being done as an in-office procedure that could even be manipulated at this point without the requirement of anesthetic, major anesthesia. So this is so far what the company has developed in the use of arthroscopic surgery, but we decided to explore the limitations of this device and see what other applications. So we actually performed a laparoscopic procedure. We performed it inside the operating room with all the requirements needed, because we really didn't know what to expect from a visualization standpoint, but the visualization was impressive. In fact, we found the endometriosis we were looking for, and the quality of the image is superb with a 2mm scope. Here we're using a 3mm trocar, but the sheath is a 2mm sheath. Where else can we apply this new technology? In spine surgery, our spine surgeon, minimally invasive spine surgeon, reviewed the product and definitely suggested it can be used as the last step of visualization before completing the surgical procedure. I also had a thoracic surgeon, Luis Argot, very excited about this device and its applications as a diagnostic and therapeutic nano visualization of the thorax. So impressive because of what it can produce as a safe and painless procedure. And one of the most important things is that, as our friend Andre was talking about, when you're looking at new technology, basically what we're finding is that all different types of technologies kind of become conjoined together and suddenly developed into something new that we did not expect. Much like what has happened with robotics. Now you have imaging, you have manipulation, you have all this technology, including artificial intelligence. So for us, it's very exciting to be able to invite our friends online globally and actually contact us and see where we can use these additional applications for miniaturization. Sometimes it's where you least expect it, but in general, we're very excited to listen to some of our collaborators here saying that they'd love to see a device like this in every emergency room around the world. So in a nutshell, that's what we have for you today: miniaturization and new technology and its applications in the market today. I thank you for your kind attention.
Well, bravo. That was a great talk, very inspiring. And for those of us who've been around for a while, it kind of harkens back to mini laparoscopy that kind of, in some ways, killed the whole notes experiment, but experience. I'll maybe start off with a question real quick. So this really moves in a different direction than robotics. Robotics, because of its complexity, takes larger trocars, if you will, and you do both robotics and kind of nanosurgery, if you will, or kind of look forward to that. What do you think the trade-offs are? Where will that line be drawn between the two technologies?
One of the things that, and again, an amazing talk by Andre, as you can see now, robotics is trying to, instead of oppose instruments, they're trying to come out through the same instrument. In other words, a single port type of configuration. I believe that this technology sooner or later is going to help these other technologies in the miniaturization process to be able to use a single port and to introduce all the instrumentation that we need, including visualization and lighting.
I don't know if robotics will be the solution for every type of surgery and every type of surgeon globally, but this miniaturization process for me is very exciting because one of the philosophies here at the Institute is to accelerate recovery. I'm not talking about something called very frequently ambulatory surgery. No. I'm trying to say that the infrastructure, physical infrastructure of a hospital, the technology and the talent conjoined in the objective of accelerating recovery. And suddenly those surgeries that would take 24, 48, 72 hours to recover in the different types of surgeries that we perform, orthopedics, general surgery, gynecology, can now be considered almost one of these types of procedures where you're seeing at least the arthroscopic procedures being done as an in-office procedure. As soon as it's done, you remove your instrumentation, you put a little Band-Aid, and the patient leaves. I believe that's where we're going to be using and leveraging these technologies in the near future.
That's great. Enas, you have your hand up for a question?
Yes, Ariel, I already see room for using this nanoscope for TEP repairs, hernia repairs, endoscopic thyroidectomies, and maybe even transaxillary approach for breast lumpectomies. But my only concern is the strength of the shaft of the scope. Is it strong enough? How robust is this? Is it going to break? Is it going to bend?
That's an amazing question, and I got your answer because I had to talk to the engineers because this is so exciting technology, and I was treating it like with, oh my God, with so much delicacy, and they said, don't worry about it, you can bend the shaft, because the shaft is actually only the wiring. The camera is on the tip that produces the image and the LED lighting. So great question, but a simple answer. You can bend it as much as you want, and it's not going to have an issue.
Well, when we're using the 5mm scope and we bend it, well, obviously the light source is affected. You don't see very well. The light completely is deviated. Is that the same situation with your nanoscope?
The nanoscope has a chip on the tip. What type of chip? It has an LED and a camera. So basically, when you see the actual shaft, that shaft only has a wiring inside that electrifies the camera and passes the camera information back and forth or back to the unit and electrifies the LED to produce light. So the tip is what you got to take care of. Now, having said that, I was very impressed with the quality of the image because you actually just touch it, clean it, and we compared a 5mm, 3mm, and 2mm imaging, and it was practically as vivid and as usable an image.
What about fogging? Is that a problem?
Actually, it was not. I was using a 3mm and a 2mm. The 3mm, as Lee was talking about, we used to love using 3mm for many procedures, using the typical Hopkins scope, which, as you know, can easily break and it's very delicate. And the 2mm, and it seems, I do not know why, but the 2mm, probably because it's generating the LED source directly on the tip, had no fogging.
Light intensity?
Perfect, except when you put two scopes. The light intensity of that 3mm Hopkins with a light source, external light source, would obscure the field because of the automation of the gain on the 2mm. But once I removed that additional light source, I had two scopes in the abdomen. I have that video. I wish I would have added it. When I removed that 3mm to compare the 2mm, then the lighting was amazing. I mean, you can light up the abdominal cavity without a problem. And we were looking for endometriosis, and it was the image that we needed to produce that diagnosis.
Well, looking forward to using it. Thank you very much.
Our pleasure.
Great. Thanks so much. Silvana, do you have a quick question or?
Yes, I think all the technical questions have been asked. I have more a philosophical, maybe comment, not question. Ariel, that fantastic presentation. I think that this is calling for portable MIS. Instead of bringing the patient to the surgeon, you bring the surgeon to the patient, and it opens up a whole new philosophy of where and how we deliver care to our surgical patients. So I think it's extremely, extremely interesting as a technology. And the only comment I have, you were talking about minimizing MIS, and that is not only related to the size of ports, but also to the insufflation, so on and so forth. So really, we have to come with a package that takes into account all the necessary techniques and steps to perform the surgery with an even less aggressive approach for the patients.
I totally agree with the comment, and this is why we were very excited and appreciate your comments because, well, these videos, as you know, are not only seen, these webinars are not only seen by our thousands of online viewers, which are surgeons and academic institutions, but also industry. Industry needs that feedback. One of the things that's very rare is that, and sometimes industry really doesn't understand that, is we don't have like a shopping center for surgeons and technology. We either go to our trade shows and once in a while we're going to see the tech, but there's nowhere where we can go online and find all this technology at a moment's notice. And this is why we do what we do at IBC, and we highly respect industry because they really are our partners in delivering the ultimate next generation care. So I appreciate the comment.
Great. I know the hour is getting a little bit long, but let's try to get in our last speaker. So we'll have to cut off the questions here, and Enas Al-Alawi is going to introduce our final speaker.
Okay. So Professor Sanjay Purkayast is a consultant bariatric and upper GI surgeon in St. Mary's Hospital in London. Professor is also a director of Imperial Private Healthcare of St. Mary's Hospital, London. He's a professor of surgery at Brunel University of London. Professor Purkayast is going to speak to us about energy and stapling technology within the operating room environment towards the first-class outcome. Professor, the floor is yours.
Dr. Al-Alawi, I hope you can hear me now.
Yes, Professor, I can hear you.
Perfect. So thank you very much, and sorry for the technical glitch in this webinar all about technology. The irony is the sound didn't work, but there we go, we're here. So thank you for inviting me to Harris Quadra, to the IBC, to the distinguished panel today. These are my disclosures, and the one disclosure that I would like to draw attention to is the bottom one, because I've started my career 25 years ago with using every single different brand, but over the years I have changed different brands of stapling and energy according to what the patients needed, what bariatrics needs, and what general surgery needs. Now, the title of this talk with regards to energy and stapling and the most excellent outcomes for our patients comes with a bit of a warning at the beginning and a warning at the end from me. And the first warning is something that I wish I could go back and tell myself, the surgeon that was much younger 20 years ago. You must understand your own limitations, the limitations of the procedure, the patient, and the technology that you are using. It is absolutely fundamentally important. It is very important to use the kit in the way that it has been designed, and sometimes that requires patience. I remember one of my bosses about 15 years ago who used to fire one of the endostaplers like it was a machine gun, and there was always stress when there was a misfire. Some of these devices have been designed in particular to be used slowly and carefully, and that's very important. The third thing is surgical experience as an individual and as a team. It is really important that we all understand tissues, thickness, tortuosity, lengths, the tissue handling, the flexibility of the tissues, and the instruments that we use and what they're made of are also absolutely key. So these three things are things I would like the panel and the listeners for this talk to keep in the back of our minds as we go through the rest of the slides. So I've designed this talk in two halves. We don't have much time, but I'm going to start with a little bit about the history of energy. And I'm sure we all know and remember from med school that Dr. Cushing and Dr. Bovey collaborated together. And that initial collaboration in the early 1900s led to the first electrosurgical unit being designed, the Bovey being then deployed, us allowing to have solid state circuitry in the OR, having contact quality monitoring so that there were no thermal injuries, less chances of arcing, instant response technology in the mid-90s, tissue vessel sealing, and now to the current gold standard that we all have in the OR, which can use a variety of different energy devices, but in a very, very safe way. So all the way through history, safety, along with energy and handling of that energy, has been absolutely paramount. We are very lucky because the laws of physics is on the side of surgeons. You can see here that the frequency spectrum and the frequency of the energy that we use means that we do not shock our patients with the energy that we pass through them. And that frequency between 200 kilohertz and just over 3 megahertz is absolutely crucial for all of these devices that are being deployed, designed, and sold to all of the different providers to remain safe. So what are the options? Well, we all know about monopolar and bipolar. I'm going to give you some examples of radio frequency and ultrasonic technologies. We have lasers and microwaves in the operating room environment. And now there are other things, for example, like the Thunderbeat that allows combination of these energy sources to be deployed together. What happens when these energy sources are deployed? Essentially, it changes the temperature within the subject. It changes the temperature at the tip or between the jaws. And the different temperatures here in green show what happens to the proteins that we are always operating on, but we never think about and we don't look for because we take them for granted. Collagen, proteins, necrosis, degradation, carbonization, cellular destruction and vaporization, and then oxidation and Eschar formation. These are the different degrees that energy can change the tissue that we operate on. And this allows us to cut, coagulate, but more recently allows us to seal. And that is something that is not just a factor of energy. It requires pressure, requires the energy, it requires time. You have to give the instrument time to squeeze the tissue fluid out. Otherwise, this invention doesn't work the way that it is supposed to. And so this smart energy, once it is developed and once it is deployed, instead of just shrinking the vessel, as in this specimen with bipolar energy, where the only way that this causes complete vessel occlusion is because there is a clot within the vessel, it causes complete intimal occlusion and sealing of that tissue. And that is why when you cut in between that tissue, there is no bleeding. And this is what this animation will show. The jaws are deployed. The pressure squeezes the tissue out. The fluid comes out. The energy then passes through. Once the energy passes through, that is where there is change of the molecular structure rapidly, almost instantaneously. An Eschar is formed. The feedback of the current, the voltage and the resistance is the intelligent part of this device, which is picked up by the generator and the data can be captured. It then understands when no more energy can travel through that Eschar, and therefore we can cut through it. Now, we use these sort of devices every day in the operating room, but it is very important that the fundamentals and the principles and the basics of this physics and chemistry is something that all surgeons, surgical teams understand so that we get the best out of vessel sealing. What do we want from energy devices? Well, as a surgeon, I need it to be reliable. It cannot be unpredictable. It must be comfortable, it must be ergonomic, and it must be all of those things for all the different shapes and sizes that we come in. I wear a glove size 8. There's other people in my OR that wear glove size 6. So it's very important that it is easy to deploy for everyone, novices, experts, trainees, students, etc. It must be affordable. It must be quick, because we do not want to keep our patients on the operating table for any longer than they need to be. It must be durable. For those of us who have operated on many super morbidly obese patients, there are energy devices that, because of the torque from our patients' abdominal walls, have snapped during the surgeries that I have carried out. In an ideal world, a wireless instrument causes less clutter. An instrument that allows us to dissect as well as seal vessels and cause good hemostasis. Something that cools extremely quickly, so that we're also able to use it as a grasper, which means that we don't need to have multiple instrument changes. Minimal lateral thermal spread, so that there isn't the old danger of arcing or danger of touching another bit of a viscera such that you cause a burn. And now, as much as we love disposable, quick, cheap instruments, we have to make sure that they are sustainable, recyclable, and ethically developed and manufactured. And fortunately, industry is working with surgeons to allow us to do these. Now, in an ideal world, personally, if we could have different options in one instrument, that would be ideal. If the instrument's plume could be reduced so that there is less fogging, there's less need to clean the scope, that would be ideal. If we could analyze plume, because we're cutting through tissues, and now there are different devices that allow us to actually put diathermy smoke through a mass spectrometer almost in real time. I've mentioned the sustainability, but it's not just the device that needs to be clever. The data that we get, for example, our generators where I work, capture the data of all of our firing, and it can be analyzed. So if there is a misfire, we can work out what the problem was. Can energy sources seal more than vessels? Could we use energy devices in the future to seal bowel, to seal other structures, such that maybe we won't need the next part of my talk, which is stapling. So I'm going to move on to stapling, which is something that historically started around the 1960s in North America. And the proponents of stapling manufacture really have been based in North America, Europe, and Russia. And that has led to all of the different companies that we have all grown up with as medical students and trainees, and have slowly evolved to be able to give us different types of staplers, starting with the reusable transverse staplers in the 1960s, then the more well-known disposable staplers, both transverse and linear. The linear cutters of the 1990s and the 2000s allowed us to also develop minimally invasive endo cutters. And now staplers are powered. They give us more information about the thickness of the tissue that we can cut through, about the speed that the blade can go through, about whether the blade is safe to cut, and even to help us choose our staple height. Staple height is really important. And I was listening to the talk from Professor Manoel about endoscopic suturing, and also listened to Dr. Al-Alawi's very, very pertinent question about suture height. Well, staple height is really important for safe stapling. And so we must know our kit, we must know the stapler. And as you can see in this image here, the majority of staples close in the shape of a B. And the reason that is what the physicists and the engineers have designed is that allows a really good closure of the tissue, but it allows good blood flow so that the staple line doesn't become ischemic, but at the same time, it doesn't bleed. To do that, we must get good compression. And that is why we need to give these devices time, because if you clamp tissue, particularly thick tissue like the stomach, it takes time to get rid of some of that tissue fluid. It takes time for some of that edema. Not a lot of time, 15 seconds, 30 seconds, sometimes 45 seconds, but that allows the tissue to elongate. It allows optimal compression, before the device is fired, such that we can get beautiful staple lines that do not bleed, and they're nice and dry at the end of the operation. And a tip to all of those listening, if you're in any way concerned about staple line bleeding, particularly, for example, after sleeve gastrectomy, one of my tips would be take all the pneumoperitoneum out, allow your anesthetist to put the blood pressure up, and then re-laparoscope the patient, and you will see which parts of the staple lines are the culprits for potential bleeding. So here you can see a walkthrough, all the different types of endostapler that we have had, from the original Endo GIA, which I have to say I used to love. I was really sad when they took that off the market, to the new powered staplers that reticulate, that turn, that can be curved, that are now giving us more data and more haptic feedback. This is a real evolution of engineering, and this evolution of engineering has occurred because of collaboration with surgeons and industry together. Now, in one of my disclosures slides, you would have seen that I was a co-founder of a company called Touch Surgery many years ago. This has become digital surgery, and it has allowed the deployment of machine learning and AI within the OR. So this slide is very biased, so forgive me. But if we're going to develop more and more intelligent devices, we must become more data-driven as surgeons. We're able to share that data better because we now have 5G. We are able to not just have multidisciplinary team meetings on Zoom and Team, but we're able to do this at the bedside for complicated cases if necessary. This data-driven operating room will allow us to have adaptive technologies. For example, in my operating room, the whole pathway is fortunately digital. Anesthesia, hematology, pneumoperitoneum, the energy source, the stapling, the video feed, all of this is digitally captured data. And that allows us to interpret what happened in retrospect, if there is any problem, if there are any complications. It allows complication analysis using the video feed. We're able to now also stream. So if people need to have live help, we're allowed to do that. This is allowing us to develop and build a surgical black box data set that includes the data from the energy generator, the data from the stapler, as well as the team performance and the video feed. And this gives us a complete cycle of data. This gives us essentially an intelligent operating room with a data hub, which is now producing data that we're learning how to analyze. And we are able to now look at these colored schematics that the algorithms produce from the generator. And actually, if you know your surgery, you can look at these tables and you can actually work out which operation is being carried out because of the deployment of the energy source. So where is this going in the future? Well, as I mentioned earlier, could we, for energy, use the energy not just for vessel sealing, but on bowel, on bile ducts, on gynecological organs? Could an energy device ever replace a stapler? I think we are very slowly getting there. With regards to stapling, I would say that the talk on the nano camera and the nano needle is also the way forward. We have been working towards 5mm stapling for a very long time. I think it's just round the corner. And currently, all of our staplers, we are still using non-absorbable metals. Could this become PDS? Could it become absorbable? Will we be able to staple with more than 90 degrees reticulation and combine new materials for staple line reinforcement that will make stapling even safer, even quicker, and even less likely to bleed? These are the things I want our audience to think about. Now, on a topical note, as I finish this talk, we all know that Mr. Musk launched his Neuralink, which is here in the corner. Neuralink might sound like a far-fetched chip to talk in a stapling and energy source talk, but we are getting very close to being able to activate devices in different ways rather than pushing a button. So although I don't want Mr. Musk's chip in my brain, I think it raises an interesting and important question, which is, how are we going to actually control the stapling and energy devices in the future? Will it still be with a push of a button? Or will it be voice controlled? haptic controlled? Will it be machine learning guided? Will it be AI guided? It is very important to have a think about the trajectory of where is the mission control of the operating room going to be in the future. 2 small slides. I don't want the audience to forget how, sadly, finance pushes and drives industry here. This is a multi-billion, if not trillion-dollar industry with energy and stapling together. And I think it is our responsibility as physicians, clinicians, surgeons, and patients to work together with industry to harness that wealth to be able to drive this for better, safer, more sustainable stapling that shouldn't just be in the hands of wealthy countries. This is something that must be shared so that developing countries can be involved in these conversations from an early stage. And we, in groups like this, must make that happen. So in summary, as Uncle Ben, that was Peter Parker's uncle, said when he became Spider-Man, with great power comes great responsibility. But that responsibility lies with the hands of us as surgeons and our surgical teams. We must know our devices better than the manufacturer and the reps. We must be ready to change and try different things to understand what is the best combination for our team in our operating room for our patients. Use the devices the way that they were actually designed to be built, and work with our patients. Explain to the patients why we use staplers and energy the way that we do. Show them their videos. Collaborate together to get safer, better, more reliable outcomes. Record your data and understand why there has been a failure in the device if it occurs. And remember that no matter how advanced things become, and no matter how much AI there is, we are the decision makers as the surgeons. Thank you very much to the team and to the panel. I'm happy to take any questions.
Very nice, very wonderful presentation covering the history and the future and across it all. Well, we're running quite late, but maybe I'll open to the panel to see if there's any questions that you might have about this great talk. All right, I might just ask you one. You presented an interesting the structure of the talk, the parallel developments of 2 everyday instruments that surgeons use. Would you think that one day one technology is going to replace the other, since they kind of do the same thing? Which would you put your money on?
I would hope, thank you very much, Professor Swanstrom. That is a fantastic question. I would hope that it would be energy rather than stapling. Because as a surgeon, the less that we leave in our patients, the better. And if with energy devices, we're able to actually change the tissue rather than leave mechanical parts within patients, particularly younger patients, children, I think that is the way forward.
All right, fantastic. Well, thank you very much. And at that, I'm going to call it quits. Some of our esteemed faculty it's 1 a.m. For Professor Chiu and others. I know everybody's busy and needs to get on. But first, I'd really like to thank the IBC team, the organizers, Professor Khwaja, of course, for inviting us all here and this opportunity to chair, and of course, all the audience that is out there listening and learning from this. Sorry we didn't get to all the questions that were submitted online, but I'm sure our faculty would not mind being contacted in the future. So with that, and of course the sponsors of these great webinars. With that, I'll say goodbye and thanks to everybody, and see you at the next webinar.
This has been an IBC University of Oxford Hot Topics in Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics in Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars as the 5th IBC University of Oxford World Congress is taking place September 17th through the 19th of 2024 at the University of Oxford, United Kingdom. For more information, go to ibcclub.org. And now let's review another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
My name is Luigi Boni and I'm full professor of surgery at the University of Milan, and I'm currently chief of the Department of Surgery at the Policlinico Hospital here in Milan. The Synergy ID system is a system that is being developed for fluorescence guided surgery. The Synergy ID system is a step forward. First of all, is an Ultra HD system, so it allows you to have an ultra high definition. And the ultra high definition is maintained also when you're working in fluorescence guided surgery mode. And that actually is a big advantage because you do not compromise the quality of the image because you're using fluorescence surgery. So we're actually much more precise, and precision in surgery means a lot. It means preserving structure that should not be cut, like nerves, preserving vessels, dissecting much more precisely, remove more tumor if actually we're performing cancer surgery. So I would say that the Synergy ID system allows you to perform a better surgery. Some other systems actually they have a little bit of a compromising, and actually the image that we can obtain, even in 4K, they actually are a little bit more artificial, a little bit more contrast. Personally, I prefer to work with something that actually gives you an image that is actually very similar to the real life. Definitely, I will recommend a Synergy ID system to other surgeons because the quality of the image that you are obtaining are actually really good. Plus, you can customize the system according to your preferences. Each surgeon would like to have the color on a certain level, they want to have the contrast at a certain level. The Synergy ID allows you to do so. So that is a big advantage. The quality of the image is great, the fluorescence mode is fantastic, so I think it's actually definitely something to recommend. Well, I had to say the Artex was a real surprise for me. Was not really well known in the field of surgery, and I knew that they were actually a big company for the orthopedics. I didn't know as big as actually probably was. So I'm actually quite happy that I decided to enter in the field of general surgery. The experience is absolutely very good. I can see a lot of professionalism going on. They listen to surgeons. That's something the surgeon like. To have a company that actually is listening to the surgeon, comes to our need, and actually focuses their interest also, not just for the commercial point of view, but also for the surgeon point of view. So I think the overall experience has been very good.
What can you do in 1 second? In 1 second, LigaSure technology, powered by TissueFect's unique algorithm, measures changes in tissue impedance and adjusts energy output up to 434,000 times. What about 2 seconds? Within 2 seconds, LigaSure can reliably and consistently fuse vessels with seals that withstand 3 times normal systolic pressure. And 3 seconds? In 3 seconds, a surgeon using LigaSure technology can seal and dissect vessels and safely move on to the next step of the procedure. 23 years of development delivers consistent and reliable performance, faster sealing, lower jaw temperatures, 3 times faster cool-down time, minimal thermal spread, less sticking. The experience of over 25 million procedures worldwide is backed up by over 1,300 clinical papers. So, why LigaSure? Being like LigaSure isn't good enough. LigaSure technology, powered by TissueFect on ValleyLab energy platforms, is the world's most advanced vessel sealing and dissection technology. It's as simple as 1, 3,